Welcome to Neurosalience, the OHBM podcast.
Today I have two guests, Dr. Natalie Voets and Dr. Andreas Bartsch. Both Natalie and Andreas have been deeply involved for many years in perfecting the use of fMRI in the context of presurgical mapping. Dr. Bartsch is currently with Radiology Bramber and affiliated with the University of Heidelberg. He's an MD PhD radiologist and neuroradiologist who studied at Charité Hospital at the University of Berlin. He also studied at Tufts University in Boston and the University of Oxford. Dr. Voets is an associate professor at the Nuffield Department of Clinical Neuroscience at the University of Oxford and a special advisor in neuroimaging at Genesis Cancer Care. She's also an intraoperative awake neurosurgery technician at Oxford University Hospitals, NHS Foundation Trust. Both have been working together to advance the use of fMRI as a complementary yet promising and important technique for guiding neurosurgery. Their work came to my attention as they've been writing, along with clinical researchers around the world, a massive white paper for the OHBM Best Practices Committee on the presurgical mapping of language function. They were also both co-authors on a remarkably clear and comprehensive paper published in 2022 in the British Journal of Neurosurgery titled Functional MRI Applications for Intra-Axial Brain Tumors, Uses and Nuances in Surgical Practice. Here we have just a wonderful in-depth discussion on the state-of-the-art of fMRI as it's used in the context of neurosurgery. While fMRI is becoming a more commonly used tool for helping inform surgeons of brain tissue to be avoided during surgeries, standards and best practices are still being worked out, as the technique itself has so many stages, including acquisition, brain activation paradigm design, processing, and finally interpretation. Natalie and Andreas are not only trained in neuroimaging, but very much in the weeds of daily surgical practice, so have extremely useful insights on all aspects of how fMRI can be and should be used for presurgical mapping. I hope you enjoy the conversation. Okay, welcome to the Organization for Human Brain Mapping Neurosalience podcast. And I had the idea for trying to do this podcast because in my capacity as OHBM standards or committee, we were trying to, we were approached by them as far as writing a white paper for OHBM on presurgical mapping of language function. And I was super impressed with what they did, and they're still working on it right now, but it's an amazing, amazing document. And I thought these are the people that really, more than anyone I know what they're talking about in terms of presurgical mapping. So with that, welcome, Natalie and Andreas. What made you interested in this? What made you interested in brain mapping? What has been your progression over the years?
Firstly, thanks for the invitation. It's really wonderful to be able to talk in an audience like this about what we're trying to do. I took a little bit of a tortuous route because I first started my undergraduate in law, but then decided actually that wasn't quite for me. And after the first year of exams, decided, I'm much more interested in how the brain works, people, etc. And did a conversion, just changed to psychology. And I had just the most inspirational teaching in Kia Nobre, who's actually our head of experimental psychology here. And it just started this flame about memory. Just after I finished, there was an advert out for somebody to join a PhD program funded at our brain imaging center in Oxford called fMRI at the time. It's now WIN. And that was under Paul Matthews, which was funded, interestingly, by Neurosurgery, who had been given a donation because an epilepsy patient from a well-to-do family had died for unrelated, nothing surgical, but the surgeon wanted to invest it rather than buy a microscope or so. He wanted to invest in a PhD with imaging because they had this interest in replacing the WADA test at the time, so the test where you anesthetize half the brain and see about memory, whether we could use this emerging technique of functional MRI. So this was now 2002 instead. So with the enthusiasm I had for sort of memory type things, that just opportunity fell in my lap. I was just fortunate to get it. And then the thing that really cemented my interest, I think, and has kept me going ever since then, was in my first year doing this PhD. I was mapping for functional MRI, language and memory, in a patient, and I look at the form, and it's exactly the same date of birth as mine. And so we have this young gentleman in front of me with this, totally opposite perspective from me here, undergoing this very scary major type of situation. I just thought, gosh, I'm so fortunate. What luck do I have that I can sort of do this? And it's never felt like work. It's been more like I get to play with something that's fascinating and interesting. So even though there have been waves of translational imaging is good or not, that's just kept me going. I think those two things. That's my
Okay. All right. And Andreas.
Yes, so also thank you for having us. Yeah, for me, I started medical studies and I was more up to go into psychiatry and child and adolescent psychiatry especially. And what fascinated me most was like the riddle of the endogenous psychosis. And I kind of always believed that there must be something in the brain to be found to understand that riddle better or to solve it. And at the time, I was in Berlin and the wall was torn down. And I also felt I want to get in closer touch with the other neuro disciplines. So I moved to I did a practicum at the neurosurgical department of the Free University Berlin. And at the time, there was a young neurosurgeon, Thomas Höll, and he had the vision to use fMRI. That was in the mid-90s, so very early on. So his vision was to use fMRI to prevent deficits in patients. And that kind of like hooked me up to that. I felt that's a cool goal. And I got in close touch with them. And he was at the time, he even hired a neuropsychologist. So the neuropsychologist was on the payroll of the neurosurgery department, which was quite unusual at the time. And we had a neuroradiologist also. And yeah, we were trying to map patients pre-surgically and to get the data into the operating room. And we also we built stimulus transmission devices into the scanner. We even built a neural navigation system at the time. And even though I pursued my interest in psychiatry further, I stayed in touch with these people. And then I moved to Würzburg and started a psychiatry residency. And also my goal was to scan psychiatric patients. And then I realized I don't understand the measurement device. So I felt I need to understand the scanner better. And so I moved to visit the neuroradiology department. And after a while, I kind of was left with mixed feelings because I felt, okay, we are putting these psychiatric patients into the scanner, but on the individual patient level, they don't get anything out of it. And they have other problems. They need support in organizing their lives and maintaining their job or not, or whatever. So I returned back, then I switched fields to neuroradiology and returned back to presurgical mapping. And that is what I have been doing for the past 20, 25 years.
Okay. All right. Well, that's all of us sort of have these meandering paths, and it's and I think that what you've done has really contributed as well. But just to start a little bit about pre-surgical mapping, why do we need fMRI? What was the state of the art before fMRI began? What is the state of the art? How has it evolved?
I think it started off quite early. I think once fMRI and BOLD came on the agenda, it took 2 years until the clinicians started off thinking, okay, we can do it in pathologies, we can do it prior to surgery, and we can kind of guide the surgery in terms of guiding the surgery in terms of, is the tissue we are going to operate on, is that functional? Does that pose a risk to the patient? And also, very important, how do we get there? What's the best access to the lesion? And what people started with was actually just simple motor fMRI. So if you have lesions close to the motor cortex, people were interested in is that functional tissue, and how close is it to the functional tissue, and what's the best route to get there? And actually, today it's still be done in the motor cortex, but much less, because we both did a critical exam on quite a large series of patients. How often do you really need it? And you don't often really need it, because the experienced neuroradiologist can identify the central sulcus and the motor cortex, even if there is a lesion with quite large mass effect and prefocal edema, etc. There are some cases, but it's just a small proportion of patients. And there have been others pointing that out. And other people, like Susan Buchheimer, for example, she told me she doesn't do it anymore. It was also in the mid-90s where people were going to the real hard topic. So localizing language. And why is language so important? It is, for one, we don't have yet strict anatomic criteria on the areas of the brain which are involved in language processing. And we may never have. So, and this is something like Exner, the Viennese neurophysiologist. He said the motor system has an absolute representation in the brain, whereas the language system has a relative representation in the brain. So you can say, well, this is, by anatomic criteria, you can say that's probably Broca's, but the idea is you're better off in functionally probing it, and you're getting spatially more precise if you do a functional test. And that's how it started in the mid 90s. So people were starting doing language fMRI using different tasks, and the first thing people were doing was just very often was just letter cued word generation, which is not a good language task. I tend to say it's not a language task at all. It's just fluency. People can be severely impaired in letter cued word generation, but still be able to communicate quite well in everyday life. That was one application, and that pertained to both resective neurosurgeries, where your objective is to resect a brain lesion like a tumor or a cavernoma, but also in epilepsy surgery, where you're mainly interested in lateralization. That is still the state of the thing. And then now we do have, like, people realize that we need a variety of language tasks. The idea is still to, in these two areas, in the tumor or the lesion patient or in the epilepsy patient, to guide the surgery or to predict the risks of the surgery.
I mean, you were mentioning as far as motor, it's easy to identify. I would have thought that at some point language from the sulcal patterns or gyral patterns that surgeons would learn to identify. It's interesting that there's this still a little bit of fuzziness as far as that's concerned.
It's still a big dispute, and even in the white paper you mentioned that we are trying to prepare with the consensus committee for the OHBM. That has been a very controversial topic. So on the one hand, you have people advocating to probe language as specific as possible, which is, in certain situations, probably the best thing to do. Like if you have a patient with a very specific deficit who has a hard time performing a certain task, like naming colors, for example, this is what you want to probe, because if this patient has a lesion, the deficit of the patient is very likely to tell you that the lesion is causing this deficit, and this is what you want to preserve. This is what you want to preserve from, or you want to protect the patient from further damage. On the other hand, sometimes it's good to have a very universal language task where most of the language areas that we know would light up, and that will help you to decide upon lateralization as well as on this best surgical route or whatever, right? So this is still a matter of dispute, and I think it depends. It clearly depends also on the patient.
Well, I just wanted to maybe touch on a couple of points that came out in this discussion. Number one was about why is it difficult to know where the language area is. In a nice, healthy brain, a neuroradiologist and most neurosurgeons can find pars percularis. Of course, there's the dispute in the literature as to whether certain anatomical zones represent Broca's or Wernicke's, and different people use different terms for that. But if we move that aside, of course, it's not the healthy brain that we need to map. So very frequently we have a very large distorting tumor there, and the central sulcus generally can be identified. But if you have something in pars triangularis and you lose your landmarks, it can become very difficult if it involves a lot of the inferior frontal gyrus. So that's where motivation comes from. The second is that I think we sort of also have to bear in mind that we follow developments in neurosurgery. So if this paper that we wrote for the British Journal of Neurosurgery was very specifically for gliomas, and actually it was invited based on the fact that the neurosurgeon, so Mr. Plaha, Associate Professor Plaha is the middle author on that, and he'd been at a conference of neurosurgeons that he'd been invited to give a talk on because they know that I and he do fMRI together. And he presented the way in which he finds it useful. And what was interesting is the editor of the journal stood up and said, fascinating that you say that, because a few years ago at ISMRM, I believe it was, we had colleague A and colleague B neurosurgeons say that there is no role for MRI in neurosurgery for brain tumors. Now, part of this, I think, is an evolution in the thinking of how and what you can treat in a glioma. So often the starting point was aggressive neurosurgeries. We don't have the published outcome series of what they were doing in the 60s and 70s when they did have stimulation. But I think generally things don't always go as expected with those surgeries. And then the thinking changed to actually a glioma in what is looking like classically essential tissue. We know that because of Broca's or case stories from the 19th century. We shouldn't touch them anymore. And now we know that actually, partly because of very brave and pioneering work from some neurosurgeons who wanted to question the status quo, and here I'm thinking Hugh Dufault and Mitch Berger and others have come along saying, we just didn't have the right tools. Let's rethink this. And I've shown that there's lots of tumors right in the middle of classic Broca's that can be removed perfectly correctly, perfectly safely with no language outcomes. So then the focus comes back to, well, how can we help inform the surgeon in their thinking to know when you can and when you can't? Because you cannot always take it, and sometimes you can. What is the variability down to? You can wait until you're at the point of surgery, but ideally we want to have that information beforehand. So I think that has been contributing a little bit to the evolution of fMRI alongside neurosurgery in this context. Whereas with epilepsy, the focus has more or less been continuously the same, unless there is a focal lesion causing the seizures. When we're talking about medial temporal lobe onset, we always have the same target. And the question is merely which side is language to inform the risks, but not to change the surgery. This is adapting now also that laser ablation or interstitial thermal therapy is coming on board. Now they can make different choices about where they put that catheter in to ablate structures. So again, now I think we will see a shift coming in fMRI applications and tailoring tasks. So Andreas and I are generally on board with ideally using more than one task to probe more selectively individual aspects of language, and that contributes to addressing the controversy that exists with fMRI is meaningful, fMRI is not meaningful. It depends what you evaluate it against. And if we don't have an option, sometimes you can only do one task. Andreas, I think, and I both favor doing a task that is going to engage the most, for the same reasoning that when you do intraoperative stimulation, a frequently used task is naming. Naming is not selective in the least and often results in errors for different reasons. So to criticize fMRI on that basis, I don't know if it's valid when you also compare it then to a similar thing. But that's so, yeah, I think there is some interesting work, especially coming out of Kathy Price's lab, where they're trying to find sort of one task that, by virtue of what you manipulate, not in the active condition, but in the comparison condition of fMRI, because you're always comparing activity under one condition to activity under another. By varying that, maybe you can selectively get everything, all the selective systems in one go. That would be very invaluable. And I think her two-picture causing a sentence is getting quite close. So we'll see.
So what do you think of maybe the people might say, well, how about like a not really a naturalistic stimuli, but just resting state. Let's say you do resting state and you parcellate the brain. If you know what parcellations might be related to language, could that be informative? What is the potential for doing resting state?
My personal feeling is that one of the reasons functional MRI is still rather contentious sometimes in terms of surgical application is this concept of how specific is it. And different people have different criteria for what they feel is specific enough to be clinically useful on a single subject basis. Now, imagine taking it to the opposite end of the spectrum, where you put a patient in the scanner, press a button, get various maps in the brain, and want to operate based on that. Here, I think we end up in the scenario that we currently, at least, have very little certainty of what some of these resting networks tell us. And I think there's great potential promise and interest if we can advance in parallel in the neuroscience developments, the concept of these connectomes and specificity in the connectomes in terms of these networks. We have to also bear in mind that we might be trying to oversimplify the brain. So there are parts of the cortex that contribute in different fashion to totally different processes depending on task demands. So how do we parcellate those at rest? Well, the point is, if those come online when you're doing something specific, then I don't really yet fully grasp how we can get a meaningful enough map out of it right now. Now, that's not to say that there isn't a value for resting fMRI. I think most of us who practice active task mapping will also collect resting fMRI because we want to build up this data set where we can answer these questions eventually. And especially useful in patients who can't do what we want them to do. And I think Andreas has very good thoughts on this. But the one thing I will add is maybe something intermediate as a compromise where we have some kind of active movie watching with certain things that we are getting them to do might be a compromise step in between right now. But I personally try never to use resting fMRI as my answer because of the specificity problem. And we will not be able to persuade more people on its value if we reduce our certainty in what we're measuring, is my personal feeling on that.
Just to follow up really quickly along those lines, looking at white matter tracks, you mentioned this in your paper as well, is critical, maybe even more critical than the cortex. And it seems that DTI or track tracing has a huge role in surgical planning as far as this is concerned.
They come together for me. It's part of the same package. I never collect one without the other unless there's very rare conditions that I can see why you would do one without the other. In our experience, although the cortex often has areas that are critical and essential, certainly at any one time point, they are more open in many cases to adaptation and reorganization in a way that in our experience, subcortical large fiber tract bundles, and here I'm not talking about maybe the cortical terminations of those, but the deep white matter core bundles, they do not seem forgiving, at least when we are looking at operative case series. So that is why preserving those is essential. And language is not in one area. Many of the functions are not in one area. Neither is motor, neither is vision. So these are connected as part of a system and a network. So we have to be attentive of the fact that we're mapping some kind of network, and the connections between them are equally essential, particularly around a mass lesion. So you have to preserve those. And we spend actually truly more time and map DTI more often. I would like to call it tractography, because I know that the tensor part of the DTI is not everybody's cup of tea. Tractography is part of the parcel and essential. In my mind, I always collect it. Andreas agrees. We have done comparisons of connectivity in rest, connectivity with task, DTI, etc. I think that's the way forward.
And it's both what during the surgery, it's not just the cortex that is at risk. It's also this, and even more, like if you have a safe access, you may be more in danger to damage one of the fiber tracts, the pathways that are involved with language, right? You really have to, one doesn't go without the other. And even in epilepsy surgery, you can get very useful information out of the asymmetry of tract probabilities. Ideally, even in epilepsy surgery, you wouldn't just look at fMRI, you would look at the fiber pathways and if there's an asymmetry between the hemispheres, right? In terms of resting state, one thing I want to add is the resting state it's a cool thing because it wouldn't require patient compliance, and we all had patients who are severely impaired, and for them, of course, it's much easier to just lie down still in the scanner. But the resting state is not a well-controlled state. That's why, some people call one of the most prominent networks the default mode network, and like Jeff, who calls it the semantic network, right? So, of course, yeah, if I'm lying in the scanner and if my mind is wandering and around, and if I'm doing this with silent speech, silent language, I will involve language networks. But if I'm more thinking about lying on a green meadow, watching the sky, thinking nothing verbally, my resting state may be totally different. And also, one of the problems is like you always, it's not just resting state, it's also the question, how do you analyze the data? And it's at some point, very often you have to go back to some anatomic region where you want to establish the connectivity with, right? So you make an anatomical choice, and then the whole thing becomes kind of circular because you're presuming this is involved in language. You select Broca's out of anatomic criteria. And then you're saying, okay, I'm seeing all these other areas connected to Broca's or having a functional connectivity with it, but you make an anatomical choice. And you're getting kind of circular. That's why, I guess, even though some people report good use of resting state fMRI, even for language methods, but most of us still prefer some sort of probing function you want to test. And I think it does make sense.
I agree. Until we understand a lot more about resting state and exactly how to process it, I agree with that.
Even in very impaired patients, you can get creative. What I have done in patients is like who couldn't really perform a task. What I would tell them is like up on an auditory signal, or even like pressing the hand of the patient, like a caregiver is in the room, and I would instruct them to silently tell their biography and alternate that with a different task. So you can adjust the task to very low levels, or even passive listening to texts does engage the language network. And if you compare that to music, where the patient cannot sing along a text with, then you can probe language.
You're talking about language. Before you talking about, we were talking about motor and language, visual. These are all the most, obviously the most. If you have a deficit, it's obvious and it affects your quality of life. But some people might argue that, well, the whole brain is important, and it seems that there's definitely a thought that, like, for instance, if you take out some prefrontal areas, it's less of an obvious deficit that you might get behavioral deficits. But is there a worry that, like, right, any part that you, what's the I guess the thought would be that there's certain, I mean, you'd think that you take out any cortex, you would have a deficit in some way. It's just a matter of whether it affects your quality of life as much. And you probably are, the surgeons are sort of making these decisions in some regard.
Yeah, but I really see it as an interdisciplinary thing, and I don't want like this is sometimes what happens. Like we do the mapping, and they say, well, it's in the end it's up to the surgeon. I really think we do it together, and we have to take responsibility for together. Like and I anytime things would go wrong or something unexpected happens, that I would always also blame it on me, right? So and yes, it's the fear is always there, even if you're in an area where you would think the patient will tolerate that, and the fear is always there that a deficit that you would not expect results from the procedure. And on the other hand, there are a couple of things we have to be aware of. Like the brain tumors, the gliomas results from they derive from gliocytic glia cells, like astrocytes. It's not neurons that proliferate. I mean, there are neuronal brain tumors, but let's take them aside for now. So the most part of them are gliomas, and astrocytes are not neurons. So it's not the neuronal tissue that is generating the tumor. And if we could, at a macroscopic level, remove all these bad astrocytes, for example, from an astrocytoma, nothing would hopefully happen, right? Of course, anytime you're operating within the brain, and that's why the paper you were referring to, and Natalie and I and Punet at the time, we had a discussion because we wrote intra-axial. For me, as a neuroradiologist, this was important. And I remember Punet saying, "Oh, they will not know what he's talking about." So intra-axial.
I was going to ask about that,
Don't
actually.
say that.
No, but I was going to ask about that. I didn't know exactly what you were referring to.
Intra-axial is like the neuroradiological term for being located in the brain parenchyma. That's all.
We're going to have such a fight now, Peter.
And that's important because anything located outside of the brain parenchyma, in the normal world, you're not afraid of a brain damage. Like if you have a meningioma that is on a proliferation of the arachnoidal cap cells and located at the dura, in many cases you don't have to traverse the brain parenchyma. So if the surgery is not going to be complicated by like the mass effect or by some bleeding or whatever, everything will be well. So the real critical issue, I mean, it's a kind of a simplification because even meningiomas can invade the brain parenchyma, etc., but then they get intra-axial. So intra-axial, the one important thing is to distinguish if you have a lesion, you want to know if it's in the brain parenchyma or not. And if it's in the brain parenchyma, you seriously consider fMRI, and if it's outside, only in very rare instances. For example, if you have to transverse the brain parenchyma to get to the extra-axial lesion, it may make sense to map or track.
Recurrence. It could be sticking, or for a recurrence.
Yes.
Like a recurrent meningioma, or it's sort of you're not sure whether the risks are language because it's like
you have mixed entities like gliosarcomas and the rare stuff. But to keep like a simple route, the distinction is important, right? So, yeah, and then I, like in my experience, I have been impressed how much of the brain you can take out without causing an obvious deficit. Like I have had patients where like tumors, oligodendrogliomas that are almost the size of my fist have been removed and the patient was doing well. On the other hand, the older I get, the more cautious I get. Because I remember one patient, and we were quite afraid of causing like damage, and I was in the I tend to go into the operating rooms to be there during the surgery. So I would be there when the surgeon operates and try to assist him. And we were very cautious because it was very close to what we thought would be speech eloquent tissue. And the patient woke up and didn't have much of deficits. And only 3 years later, when he came back, he would later on report upon very slight deficits that were resulting from the surgery, and that his wife confirmed. So you have to be very close to the patient. And patient also, something you have to realize, they are not an object. And they are ashamed of their deficits. For example, I had a patient, and she due to a tumor, that tumor caused her to have lost her ability to read. And she was working in a supermarket, and she had to put goods in the shelf, and she couldn't do it anymore because she couldn't read the signs. And she'd rather quit her job than to admit her deficit. Patients are ashamed of their deficits, and you have to be, they have to trust you to tell you what's going on with them. So, and the closer you follow up on your patients, the more slight deficits you will see. So yes, and we are still, in a way, what we are doing is still very much on the surface. We are trying to do the big things like language, motor system, vision. But other stuff like praxia, like if or agnosia, and higher cognitive functions, we barely yet map, and that's something that I hope to see in the future more.
I just wanted to add one thing, Andreas. I think because if we're talking in the context of gliomas, Peter, talking to your point, why do we focus on certain systems much more than others? Aside from the fact that we are better at mapping certain things than others, leaving that aside for a moment, I would like to highlight the clinical implication and reporting of those symptoms may impact on follow-on treatment in a way that it doesn't for, let's say, personality change. So if a patient has suddenly an inability to walk, their performance status will affect whether they're deemed suitable to undergo radiotherapy. Now, if they have a glioma, most commonly they have an aggressive glioma. It's just the way statistically it works, and they need radiochemotherapy. So if we do surgery that results in a deficit that involves dysphagia, mobility issues, or vision in an aggressive way, it may undo the benefit of surgery for the reason that they cannot then have their follow-on treatment. So that is why I think there's a focus on that. And that doesn't mean that we shouldn't map the other things. Certainly, I work with a surgeon who is very interested in neglect. It does also is very debilitating for the patient, even if it doesn't affect their treatment. And similarly, there's this sort of contention in the literature. Let's say a right frontal tumor, if it involves certain parts that are close to a fiber bundle called the inferior frontal occipital fasciculus, also sometimes called the IFOF, or the other way around. Certain surgeons say you must operate that awake. Other surgeons say it really doesn't matter. We have now 3 patients whose relatives expressed very substantially after surgery, this is not the same Michael, or whatever the patient's name is. This is not the same Michael that I know. Now even if we did properly test everybody, which is another issue in the whole literature, even if we followed everybody up, we're not going to catch a personality change. And how do you map that with fMRI, and how do you monitor it with surgery? So we do have some dilemmas with just how our knowledge of how the brain works. So I don't think that they're not important, but we have to also be aware of what we can physically, practically map, and what is mappable. Can we map something like neglect and hemispatial attention if it isn't that one area contributes function A and one area contributes function B within this network, but maybe A and B both needed? It might not be mappable in that way.
And just to follow up on that, I mean, you brought up a really good point in terms of follow-up. Obviously, the bottom line is that, you want to, I mean, even for neurosurgery in general, but also, as we're talking about fMRI, is it really making a difference? Is it really, and not only in terms of whether was the surgery successful, and then in the short run, did they have deficits, but, was it worth taking out whatever the lesion was, and was, do people follow up in terms of the quality of life difference, fMRI versus not fMRI, whatever. Have there been studies that will say, based on the follow-ups, long-term follow-ups, that fMRI is really worth it?
Too few, if any. I mean, this is what actually matters, right? So we are, in a way, we are in a dilemma because, of course, the first thing we want to prevent is a new deficit after the surgery. We don't want the patient to wake up and being aphasic. We don't want that. On the other hand, if the aphasia would go away, or if it would go away to a level the patient can live with, and if this, like a more extensive surgical resection, would prolong the patient's life, then it may be worth it. And yeah, we definitely need follow-up. And we don't have much follow-up studies on neurosurgical patients. We do have good follow-up studies on stroke aphasias, for example. And we know that most of the recovery that occurs within 1 year. And we do know that, for example, we do know for sure that the size of the stroke does matter a lot. So if you have a large stroke that presents with a global aphasia, that patient is not very likely to improve much. If you have a small stroke, people can recover to a surprising degree. And we probably, so what we hopefully do, or this neurosurgeon hopefully does, is only minimal damage to the brain. So yes, maybe we must at some point think about, can we predict recovery from some deficits, even in surgery? But over the past 20 years, it was mostly focused on preventing a new post-surgical deficit immediately after the surgery. But that type of thinking is kind of switching. And it's also changing in terms of, some people advocate the use of like 2 or 3 stage surgeries in patients, right, Natalie? I mean,
Yeah, we do that, and we use fMRI a little bit for that purpose. I would say I'm aware of 3 lines of evidence, and none of them strong. So there has been at least one randomized controlled trial that I do know of, but it was in arteriovenous malformation patients, and they took all comers. So microsurgery for AVM with or without fMRI, and they're also adding tractography often. But the lesions were not selected for being anywhere near particularly a type of thing you'd worry about, whether it was motor or language. They did do a later sub-analysis of did it change or not. Now, the trial was, if I remember correctly, was abandoned early because the risks of microsurgery are so low anyway that they felt that there wasn't a change in those branches, and they stopped the trial. Now, let's move then to evidence in more relevant populations like epilepsy and glioma surgery. Certainly, there have been, in the earlier days, case reports or small case series that said, look, if we blinded to the fMRI results, look at what happened to the patient, then if the surgery included areas that were activated on fMRI in epilepsy study patients, they had language-related errors after surgery that were not present if you didn't take the fMRI activation areas. And some people have shown that even if the surgery included intraoperative awake testing with stimulation of the cortex. Now, what we don't have, and probably because of a publication bias, is studies that show the opposite, i.e., we took lots of fMRI activation, made no difference. But those are, while not published, they are reported in surveys, such as those by Christopher Benjamin, who did a survey of epilepsy centers. And they say, have you ever encountered areas where you ignored the fMRI results and where the outcome's okay? The difficulty there is partly in the interpretation. I frequently have the surgeon tell me, oh, that patient is totally fine, they have no deficits. But if I see them bedside and I look at repetition and picture naming and reading, they will have impairments on some of those subsets. Now, they may not have overt problems. Again, if we don't follow them up properly, I don't know. So those three lines of evidence together lead to this equipoise in the literature and in practice of, do you use fMRI or not? And I think it comes down to whether you had a good experience with it or not.
Yeah. So how many groups do you think are using it worldwide right now? I mean, obviously there's different levels of use, but I can't even get, because to me it's like some people might say, well, maybe 10 or maybe 100. I don't even know the order of magnitude right now.
I know the statistics of the centers that sort of do it. So about like just under half of centers that do imaging in glioma patients. But what I don't know, and Andreas might know better, is what kind of number would that be? So centers that do glioma surgery and imaging for it, let's say across Europe, I'm just not as aware because, of course, I have in mind.
Well, yeah, there has been some statistics on it, and it's actually it's right. A survey on centers doing glioma imaging and surgery, it was about half of the centers in Europe doing it. The problem is that they had less than half of the centers responding to the query. So I would say in Germany, it's probably around 50 centers doing it. But the quality of what they do varies greatly.
Yes. And so that's actually, and so that's a perfect lead into, I mean, and obviously you're talking about in your white paper standardization, but and there's a lot that goes into this. Everything from the acquisition, the pulse sequence, to immobilization, to the paradigm itself, which there's so many different, as we talked a little bit about. What is the right set of paradigms? To me, the pipeline and the analysis is huge in terms of how is it done well? How is it done in a timely way? How is it done such that, and in your paper you mentioned, and which was a really good point, in that usually in typical fMRI research, you want to avoid false positives, but in surgery you want to avoid false negatives. And how is that adjusted? And how does, usually when you have a surgeon or a radiologist looking at a MR image, they have control of the level of and window, and so they can just work with it and see what they need to see. In fMRI, it's these are statistical maps. How do you do that in a way that makes sense? And then also finally the interpretation, as we sort of hinted upon as well. I mean, people have vascular deficits. Maybe there's altered neurovascular coupling near the lesions. It seems like so much of it, like a lot of medicine in general, it starts with the science and kind of turns into an art in this regard. But so, yeah, I mean, what would you say? I mean, do you have hope that we'll have like a standardized? I mean, obviously we're moving in that direction, but it still seems like processing and that whole level of from acquisition to processing seems it's wide open, and there's so many people doing it, and there's so many people doing it different ways. Will it get traction, and will it settle in? If so, how?
Well, a couple of things we can't change about fMRI. fMRI, for one, it's a functional in vivo test. It doesn't tell us, it tells us if everything goes well, it tells us an area that lights up is involved in the task. But you don't know if it's essential. If you don't know if it's dispensable or not. So we have to live with that. And we won't be able to change that unless we it's not a reversible lesioning thing like VADA testing or intraoperative electrical stimulation or whatever. So it's a different type of test, which is in a way bad, but in a way good, because it allows us prior to the surgery to do a wide range of tests. Whereas if you do like in VADA testing, you only have a short period of time to do the test, right? So at some point, you can't repeat it again and again, because at some point the patient gets sedated. The patient passes out at some point. So you have a very small time window. So the reversible lesioning, and also, I mean, one thing fMRI has been criticized is, although it's certainly better spatially than old SPECT or whatever, that it's still not functional enough. Like ESM would be functional, which is not true. Like even if you do cortical stimulation, it has a certain point spread function. And if you ever happen to be in the operating room, look at a brain, and if you see how it's going to be stimulated, depending on the simulation level, you can see the brain getting kind of gray, and it's like an area that gets a little bigger. So you can see a response, and it's not very functional. This has remote effects, certainly. So it's not the idea that it's like a needle that you stick to the brain reversibly, and that's the point that's critical. It's not true. The other thing is that fMRI is a probabilistic. We do whatever we do with the data, it's time series data, and we get some probability of activation. And the surgical decision is binary. Do you cut or do you don't cut? And how do I get that? It's a binary decision. So we have to reconcile these two, but in our, and yes, this is not very scientific, but in our experience, it is still useful. It is still useful to tell the surgeon, oh, in this situation, it's better to come from the back of the lesion because you're less at risk to damage cortex, critical cortex or critical fibers. And in the other situation, it's better to go in front. And here you have also to establish the relation to markers of the skull or the superficial veins of the brain are important to guide the surgeon, or to guide the surgeon in terms of where to perform the electrical stimulation during the wake surgery. Because some people do huge trepanations and stimulate everything they can do, but these are very long operations, and ideally fMRI can be helpful in guiding stimulation intraoperatively. But that doesn't take away the problem of fMRI being probabilistic, and at some point, yes, you have to decide what you consider relevant or not, and it's very hard to put this on scientific grounds. The only thing I just don't like is, like, if you compare it to the neuroscientific literature, what we were afraid in the neuroscientific literature, when we want to publish a science paper, we are afraid of false positives. We don't want to set a claim, okay, this area is involved in whatever, processing this or that, and in the end, it turns out this was a false positive finding. We are afraid of that. Whereas in resective, at least resective neurosurgery, we are mostly afraid of false negatives in terms of we are afraid that we say we declare some part of the cortex irrelevant and the surgeon cuts through it and the patient has a deficit, right? So false positive control in terms of protecting from false positives, the fMRI results, is simply the wrong question to ask. And that's very important for people to realize. And if you look at the fMRI, the clinical fMRI literature, what people still do is they report false positive probabilities. And it's just, you have a patient, to put it the other way, you have a patient and you confront the patient with a task. And the patient can perform the task, maybe at a reduced speed or whatever, but the patient performs the task. And what you're saying when you protect yourself against false positives, your null hypothesis is there was no activation at all. That's what you're saying. And you're trying to convince yourself that at an error rate less than 5%, the activation you're seeing is real. This is not the question you want to ask in the clinical context. And I have been, over the past years, I have been doing some work with other people like Tom Nichols and people from a mathematician, Tim Johnson, where we try to find alternatives, ways of framing this question and to analyze the data statistically.
certainly people have, there's effect size maps, and that's continuous, and you could sort of like have something that you can kind of look at and make a judgment about, as opposed to relying purely on the statistics in that regard.
Yeah, and this is something what we supplemented the normal like false positive controlled maps with other layers of maps. Yoki Durnes, for example, we published a paper on that, and we are trying to put this into the awareness of the people. So ask the right question, and the question depends also on the surgical objective, right? So, for example, if you have a cochlear implant patient, in that situation, false positive control is a good thing, because if you want to make sure that the activation you see, for example, by trans-tympanic or extra-tympanic promontory testing, does activate the auditory cortex, because so the idea of presurgical mapping prior to cochlear implantation is to do fMRI to show that there's at least some residual integrity of the auditory system. If the auditory system does not work at all, there's probably no point in putting a cochlear implant in. So if you want to protect, in that situation, you want to protect yourself against false positives, because you don't want to subject the patient to the risk of the cochlear implant surgery without having enough evidence that he's going to benefit from it. On the other hand, you could also argue, well, but I want to give him a chance, right? So I'm still afraid of false negative, because if I'm erring on the false negative side, I'm taking away the chance for this patient to restore hearing, right? So you really have to weigh in what is important for that particular patient, and that differs. There's some things we can't change. We can't change the fact that fMRI does not tell us which regions are essential to perform the task. We can't change the probabilistic nature, but please ask a reasonable question to your data.
So okay, so I mean, it almost seems like all these things are this art. I mean, it's all for the field to evolve. It seems like there could be like a company, not really a company, or it could be some sort of a group that makes a package that standardizes things, at least from the paradigm to the processing, that people can adopt or groups can adopt. Obviously, there's a lot of, like you were saying, a lot of decision making at the surgeon level, but having something that would allow better dissemination of the best practices, aside from the white paper that you wrote, aside, something that vendors, like the scanner vendors, don't really want to do this. And so it seems like a third party it could push the field. I mean, I don't know.
Some of this does exist. So although we're writing a white paper, what we're trying to do with the white paper is actually address some of the gaps that have been left in previous calls for standardization and previous recommendations. So allowing for the fact that it's nuanced, fMRI is nuanced, there's subtleties in the acquisition and interpretation. We have to ultimately accept that for it to be useful, there has to be maybe a commercial entity that can get a certain package, like you're talking about, approved for use. There have been recommendations by the American Society for Neuroradiology, and also by research group. Chris Benjamin has put a suggestion of tasks in lots of languages up and online and available. Excellent resource, very, very important resource. ASFNR recommended a certain set of tasks in a certain order, and there are companies like Nordic Neurolab that have implemented those recommendations within their commercially available software package. Other providers are available in case required. But so I don't want to make the impression that it doesn't exist and that we're starting from nowhere. I think what is important is that there's difficulties in collecting meaningful data, and then there's difficulties in knowing how, understanding and interpreting the meaning of that data. Some of that, yes, I have high promise that we can standardize that. Aside from vendor differences, we're going to recommend sort of range of acquisitions that should be appropriate, a range of tasks. What we're addressing with the white paper that is new is that there has typically been a focus on this is the active task you should do, and there's been very little concern or attention provided on what you compare it against. And if we want to move the field forward and address these criticisms about specificity and outcome validity, we really have to think more carefully as a whole community about how to interpret those maps. There's always going to be an art in interpreting the maps. In the same way that a surgeon knows this is tumor, this is not tumor. You can't just show slides, they acquire it from feeling it. So people with a lot of experience in looking at an imaging map will know this map does not make any sense. This map is probably artifactual. There's some motion there. You just know it from experience. We don't have training. That is the thing that I think is more difficult. You cannot just read in a textbook, this is what a glioma looks like on T1 contrast. You do need more experience and training with that. And multidisciplinary interpretation, where it doesn't go from any one person to the other, and you give a map and the surgeon says, oh, well, this means the right hemisphere has taken over language. No, that's not what it means if you see right hemispheric activation necessarily. So understanding that properly through mixed experience and training, I think, is where it needs to go. And then a commercial approach will follow, we hope, by implementing some of the recommendations about, for example, alternative hypothesis testing. And indeed, there are several initiatives also in the research world that may lead to spin-outs with tools more tailored for this. So I think watch this space. None of this moves fast, but we can move forward because it's a unique problem of the N of one, and everything we have available is dedicated towards group studies. So once we have more drive in the clinical uptake and more clinical groups push for better things, we will be able to get there, I think.
Of course, if you have companies, and we do have companies who offer solutions for presurgical method, and this can be a step forward. It can provide centers who are not ready to do with a good set of stimulus delivery equipment, with some sort of analysis strategies, etc. That scenario would be, and I'm very afraid of that part, is that you just have centers who want to say, oh, we're doing fMRI, and this is, we can generate like fMRI maps, and the patient is not seen by anybody, just comes in, some technicians pushes the button, it runs through some pipeline, and the people don't even look at the data anymore. And then this is sold as progress, and it's not. And it's dangerous to the patient. Because what we are saying is you should examine the patient, then clarify the objective of the surgery, clarify the objective of the medical decision that is about to be made, and then collect your data. And then during the analysis of the data, check every step. For example, it's not uncommon that brain lesions are present with signal loss, like AVMs or cavernomas or bleeds in tumors. And many analysis packages just do brain masking. Brain masking often to reduce or to limit the analysis to the brain often involves some sort of intensity thresholding, where the lesion itself is excluded. So I have seen papers, and I remember conversations with people presenting data from AVMs, and they were saying, oh, we checked these AVMs, and there was never activation in the AVM. And I said, well, but did you check your mask if the AVM, the inner part of the AVM, was included at all? And then they would contact me and say, they were excluded in all our cases. And that's the risk of these automatic analysis pipelines. And and I have always been struck by the fact that in science, we are making so much progress at all levels, like distortion correction, etc., processing of the data, cleaning up the data, removing motion effects, etc., etc. And in the clinical part, it's just lags behind so much. My objective was also, I never understood that. I mean, if science is ready, we should transfer that progress to the individual care of the patient, right? So, but that requires us to be very cautious about anything that can be, is sold out of the box.
Right. And yeah, and right, there's this skill, and that's taught, and right, it all comes down to right the amount of attention to the quality of the treatment from the surgeon on down to everyone. That's something, right? It's hard to package.
We also do get issues like legal issues. For example, there are some packages out who have FDA approval for fMRI, and it's not clear if or how they do, for example, distortion correction. And it's very obvious that correction is something you should do. Like if you have a patient who has been operated and who has a trepanation and that is fixed with cranial fix, you can have displacement of easily 2 centimeters of your activations. But then if I'm using latest state-of-the-art distortion correction, which is obviously better, like by collecting phase-reversed EPI or traditional gradient echo field maps. If I, for example, want to use FSL tools for that, I'm theoretically not allowed because it's not certified for patient use. But something that is obviously worse is certified. So if we have to measure ourselves about things that are obviously worse, something is going wrong. And this has influenced our discussion for the white paper, because in Europe right now, the whole discussion on the medical device directive and medical device regulation thing, MDD, MDR thing, is a big thing, and it puts up huge challenges. And yes, of course, we have to protect our patients. And maybe in the old days, we were kind of a little adventurous in taking patients to the scanner and saying, "Oh, it doesn't harm the patient."
Right.
Doing things, yeah, right. So and yeah, you should think twice what you do with your patients, or maybe more than twice. But still, if I know that something is better, I should be able to do that, right?
Yeah. So I'm mindful of the time, but there's so much we could talk about. Maybe we'll have to have another follow up, but because we really have only scratched the surface. I'm curious about like things like epilepsy localization and other things like that. Actually, I can't help myself. I remember early on in the field. Just to switch gears completely and just very briefly, there was hope that fMRI could localize, epileptic foci just based on, the resting state correlation, and then combine that with EEG. And then so you could actually see, and it seems that, that area would, even if the patient wasn't having a seizure, that area would show this abnormal activity. And it seems that sort of has not really panned out in that regard. And it's now you're still relying on sort of anatomic, structural differences or things like that. Is that true, or is that sort of thing making progress?
I personally think that actually there are groups using this very successfully and that it has shown promise. It's just that the subset that need that is a very small subset. Now, based on resting fMRI alone, again, I don't think so. And part of the reason is that functional connectivity as measured with resting fMRI is also susceptible or weighted by things like volume. So if you have atrophy in the hippocampus, you should expect to see either increases or decreases of your functional connectivity profile if you don't account for volume. We've published that in Brain and nobody's read it. And you see so many papers about resting connectivity shows reduced connectivity of the hippocampus. That must be the one to blame. You're like, did you correct for volume? So I don't agree with that, only because people aren't careful enough to control for everything and be sure and then put electrodes in. Because the consequences of how you're interpreting the data are non-negligible. You're talking about removing a part of somebody's brain. So, however, with simultaneous EEG fMRI, I think there's been beautiful work, very nicely characterized and well done, that shows that the combination of both techniques, where you use fMRI in a way to help localize the source of interictal, so between seizures, discharges, has identified, and has been useful in many ways, has been useful to confirm the location of a lesion, the location of seizures particularly when you don't see a lesion on the MRI, and that's the use case. But also vice versa. It's been useful to show that actually the seizures are arising from many locations, and this patient is never going to be a good surgical candidate. Therefore, let's remove the need for excessive invasive testing. So I've also seen data that reports then the outcomes of those decisions. So where surgeries have been done based on including the areas that were activated with fMRI and showing successful outcomes. I'm not too aware of negative reports, but again, there may be a publication bias, so we have to be aware of that. But I do think that that field in specialist centers is moving forward with promise. The reason it's not more widespread, I think, is merely because it's very time consuming, technically very challenging to set up, acquire, analyze, etc. So specialist centers do it very well. And I'm talking specifically of London and in Canada, they've got good groups there. Andreas, do you have a different story on that, or do you think?
No, right. So everything what you said is just true. And the thing is, in terms of epilepsy, first, you don't necessarily want the patient to seize in the scanner. So some people have done that. Some people have done that to scan patients seizing in the scanner, but it's not something you generally want to, because you want to take care of the patient. I mean, you don't, like, if you deal with epilepsy patients, you don't have to interrupt a seizure right away. And sometimes, like, especially if you have if you've never seen the seizure, it's very helpful to meticulously observe what happens during the seizure. It tells you a lot also about where the seizure might be originating from. But you don't want the patient to generally seize in the scan. So what you were saying, Peter, is right. So what you see is intra-axial abnormal electrical activity, and the idea would be to localize that. And yes, you can do that. You can simultaneously record EEG and fMRI, and then check what bold traces can you track out of these intra-axial discharges. And the problem is, when you do that, what usually happens is very often you just don't get a single spot. I mean, that would be the coolest thing if we would say, okay, EEG has problems in spatial localization, even up to inverse localization errors. And what we do is we take the spatial certainty or the spatial specificity of fMRI to the EEG measurement from simultaneous EEG fMRI. Now the problem is, what you commonly see is you see a whole lot of areas, even in the hemisphere you don't think where the seizure is originating from, lightening up. If you believe these activations, then the patient is no candidate for epilepsy surgery anymore, because you usually don't. You usually don't do bihemispheric operations. You just do it on one hemisphere. I think what you can actually do, what has been done is simultaneous EEG fMRI can be helpful even to guide placement, for example, of subdural grids to further localize and can reduce the extensiveness of the invasive preoperative workup. It does have an impact, and I think it can be clinically useful. Just the technical challenge is big. Just to get the EEG recording along with the scanning running well and to analyze the data, right, it's a huge thing. It's very complicated.
And of course, 7T is starting to show more of the lesions that we haven't immediately seen at 3T. So I think as technology evolves, there may be more or less need for that.
Many cases that have in the 80s, 90s, even probably up to 2010 been called non-lesional epilepsies. Now you can identify using 7T, but even 3T, you can identify putative seizure onset zones structurally. So this is evolving, and fMRI still can have a role there, not for the structural part, but for the functional part.
It might also be cool for identifying where to implant with a DBS electrode as that starts to maybe become refined in the circuits. Then if we consider it as a network, that might become interesting. And then we end up with spatial specificity issues, but these will be addressable, I think, as well.
Yeah. At 7T as well, with higher contrast for the subcortical nuclei, as well as, functionally as well. I mean, you might be able to get higher resolution. So that's huge, right? I think that would be cool. Yeah, we'd like to get more 7Ts. I'd hope it's sustainable. I mean, I hope that's a whole other podcast as far as 7T. I love, I love 7T, and I think it has a lot of immediate clinical applications. But the cost is very high. So
it's high, and also the problem with the specific absorption rate, right? The energy you're putting in. So I remember the opening of 7T scanner in the Netherlands, where they had to pause for like half an hour to continue the scanning.
Well, or to get the patients in there in the first place. Unfortunately, many of the epilepsy patients with drug-resistant epilepsy have a tendency to fall downstairs or break a limb or this or that, and then you put a metal pin in and they can't go in. So I have done a 7 Tesla epilepsy study where unfortunately the safety considerations led to 50% attrition rate. You just couldn't put them in the scanner. So until we get a better sense of whether 7T can become 3T with those issues addressed, then those are different podcast topics, as you say.
Yeah, no, right. I mean, that would be worth a podcast as well, because some people feel it's sort of a continuum, and people just figure out how to have like, for instance, safety or for implants or things like that, or SAR, specific absorption rate is like better pulse sequences, more efficient. Yeah, we see effects, but I don't quite see that. So that's actually interesting, where 50% attrition rate is pretty high. So that's something to be aware of, at least.
Whenever you go to a clinical population, I think we have to remember we don't tackle. It's the same with the anatomy. We can see it in a normal brain, not in a tumor. Whenever you want to put patients in a scanner, tattoos in certain populations, very high prevalence, implants, it just becomes the norm for us.
Yeah. All right. Well, on that note, just one last question, not necessarily advice, but any sort of perspective on the future on for if people are interested in getting into it and trying to push this part of fMRI as far as presurgical mapping. What is your sense of, is it worth it? Are you optimistic, and what timeline as far as that's concerned?
Optimism, obviously. Timeline, well, it depends on what the timeline is, whether you mean timeline for clinical uptake to be expanded or timeline to get some of these niggles sorted. I think consensus and standardization must be, there's such a focus on it right now that I think in the next few years we'll be able to advance that field. I think once we have enough drive with the community about what it should be, then the companies that do it can get on board, and new companies that want to do it well can develop that. You agree, right? Yes, you agree. And then in terms of what to say to people who want to get involved, certainly there's a lot of interest in helping people who want to do this well, and training opportunities can be made. If they don't currently exist and there's an appetite, then maybe through OHBM feedback we can understand what kind of things we can make there, and we can definitely do that. If it's on a more personal scale, I think as a practitioner of any technique, even if you believe in your technique, you should be willing to self-validate and be willing to build up enough confidence in your own stuff and validate and question yourself, is this right? To be able to persuade those who don't agree. And sometimes people will challenge you, not because they don't necessarily agree, but rather because they want to be persuaded better with data. And so don't be afraid of that. It's not a personal criticism, I think, when people say fMRI doesn't work. I think what they're saying is their experience hasn't worked well for them. And we can engage in conversation about what would it take for them to gain enough confidence to either give it another go or apply it in their own site. And that's what this dialogue, I think, is about.
That's a great point. That's a really good insight. Yeah. A lot of people take it personally, or else they feel like, oh, well, that's maybe they're right or whatever. It's just,
And that's the interdisciplinary nature of the thing. We've been talking about standardization, and we may, and that's important, but standardization, we don't have to be obsessed with the level of it. That's why I like to use, I like to call also what we propose in the white paper, I'd like to call it more recommendations for meaningful use. It's to alert people to the problems they will encounter. And then, yeah, they advice for anybody who's interested in that. It's just my advice would be just stay curious and engage with the people you're working with, engage with the neurosurgeons or the other people who take care of the patients, try to understand the patient, and also, yeah, get involved with people doing it. Like, and hopefully the white paper will be some stimulus toward that. And the idea is to put it on the website of OHBM and to get feedback from the people. So have a look, tell us what you like, what you don't like, what your experience are, what if you have other opinions. We may not be able to incorporate everything, but hopefully this will bring the field forward. We need to discuss things, and we need and that's why this has become such a massive effort and such a massive paper and document. It's not to overload people, but to touch upon all these issues and to bring them into the mind of the people, and not just stay on the surface of just what paradigm to use, but also even touch upon the how to report fMRI results. What's the best thing to do that?
yeah, exactly. I think that it's definitely not just purely just a recipe. It's more like like, oh, these are all the issues from this collective experience of authors of the things that are being dealt with, and it's probably an invitation for more people to sort of take part in this. So I think it's, yeah, I hopefully this will get onto the website soon and keep on going from there.
If you have lots of people being involved, it just takes time. But we have been getting good feedback from people who are still missing some feedback. So yes, we are still optimistic.
Well, that's good. It's always good. It's always worth having hope, and certainly here it's definitely, there's 100 pages already written, and it's ready to go. It's ready to go. So great, and certainly the field itself. I think that there's no indication that it's reaching any sort of dead end. It seems that it's just the opposite. It's more nuances, more interesting things, more technology, more opportunities. So I think we just have to keep on learning to grapple with all these issues.
And it's worth it. It's like, I mean, science per se has its value. There's no doubt about it. But my vision is still like, if we have this technology, we should be able to bring that into use for the better of the patients. That's what we have been doing. And for me, it has been such a pleasure to get to know people across the world doing this and collaborating with you, Natalie. It's a huge benefit to have somebody you can share your thoughts. And I remember all these discussions about very peculiar patients and things we have observed. That's just what keeps us alive, I think.
Maybe that should be part of the training, is a sort of worldwide multidisciplinary team grand round where we can say, oh, this didn't make any sense, or what would you do about this? And
maybe we should do that. And we actually, ESNR had the plan to do that in fMRI, to do like a what FSL or SPM course for clinical analysis of patient data. And Corona just killed that.
Yeah.
We're still on it. And Natalie and we have been thinking about maybe we should do something like that.
we should do something like that. We should. And we can engage other things as well, like, the pharmaceutical industry in terms of tailoring patient-specific responses. A lot of that with fMRI for pain, for example, and other drugs, recovery and stroke. fMRI has a role there. So unifying a little bit the applications and bringing it through real life illustrations can help, I think, address and overcome some of the challenges that people report. So that can be a dialogue area.
Yeah, I mean, if you measure liver enzymes to establish the effectiveness of a drug, why shouldn't we measure resting state fMRI measures to establish the effectiveness of drugs? In the end, of course, like with the recent Alzheimer's medication, in the end, it will matter if it is good for the patient, right? So outcome will be crucial. But yes, this is all something to come. To broaden the perspective. So it's not just presurgical, but this is what I have been doing. I'm very simple-minded, so presurgical has fit that.
All right. Well, this has been really, really great, and I really thank you for coming on and spending the time, and think that what both of you are doing is really not only really high quality and really great, but also pushing the field in a way that's really important. So appreciate that. So
thanks for offering the platform.
Thank you, Peter.
Neurosalience is brought to you by Organization for Human Brain Mapping. This week's episode is produced by Ömer Faruk Gülban and Jeff Mentz.